Um, Hello, everyone. I am waiting on a quorum, and once I get a quorum, we will start. Okay, I thought five. I thought I needed five for this. Oh, there we have five. Okay.
Got it no matter what.
Okay, perfect. Um, are you ready? Is IT ready? Okay. Well, thank you so much. Okay.
Recording in progress.
Wonderful. Well, good afternoon, everyone. Today is October 23rd, 2024, and it is 4:04 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I would also like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee, Executive Committee, and the Board of Managers meeting at a time certain of 5:30 p.m. unless a member of the public wishes to comment on a specific item on this agenda. We will now proceed to the Budget and Finance Committee. Members, we have a time certain of 4:30 for item number 4, which will require that we will go through the first 3 item agendas as quickly as we can to ensure that we are at our time certain. And I am going to be taking the agenda out of order. We are taking agenda item 1, 3, 2, 4, 5, 6. So just the first So I just wanted to let you know. And yes, ma'am. I'm going to take agenda item 1, 3, 2, 4, and 5, 6. So I'm just switching 2 and 3. We'll try to make this meeting efficiently and great. So now moving on to agenda item number 1, approve the minutes of the September 25th, 2024 Budget and Finance Committee meeting. I move that the committee approve the minutes of the September 25th, 2024 Budget and Finance Committee meeting. I have a second by Manager Valdez. All in favor? Anyone abstaining? No. Do we have Manager Jones online?
He doesn't have his video on.
Okay.
Is he on though?
Manager
Yes,
Jones?
yes, I am on. I'm sorry.
Okay.
Yes, I am.
Are you a yes for the item?
Yes.
Okay,
Yes.
thank you so much. With that, the motion moves. Now moving on to agenda item number 3, receive a presentation on the September 2024 financial statements for Central Health, including capital projects. Jeff Canodal and Nikki Riley will be presenting.
Yeah, thank you. Good afternoon. Just in order to be expedient, I'm going to go through just the highlights of our September year-end financial statements. These are preliminary statements, and the one thing I can assure you of is they are preliminary and they will change by the time we get to audited year-end financials. So with that in mind, if we can go to the highlights. Thank you. And I'm probably going to add a few. If there are any questions or anything, if we can just route them through, Brianna would be fine, and we'll certainly get back with you. So starting up at the top, September fiscal year to date, property tax collections. Again, this is our primary revenue source. The good news is it's at 100% of our fiscal year 24 budget. We still have some year-end adjusting entries to do, so I suspect that number will change, and so we'll report back out on what that change is. Another metric that we use related to property taxes, the collection rate related to our adjusted tax levy, and you see that it's 97.2% in the current year, and last year in fiscal year 23 it was 97.6%. So on par with what it was last year. Secondly, interest income is $32 million year to date. Again, we have some year-end adjustments to do to this, but that's significantly over budget. Which is good, which means rates have stayed high. We've received more interest income than what we foresaw as we developed the budget. Number 3, the LPPF restricted balance as of 9/30/24 is $2.7 million. And on the opioid funding, if you remember several meetings ago, there was a resolution that you approved to accept funding. The state did disperse funding slightly earlier than what we thought. They dispersed $4.6 million, and you'll see that in the September financial statements also. Next, so the Sendero high-risk claims advance. And again, as a reminder, this began in January of 2024. That advance amount is $15.9 million as of September 30th, 2024. Excuse me. So we've also included, let me go back. Healthcare delivery is at $230 million for the year. September, again, this number will change. It's compared to $160 million from the prior year. As it stands now, that's about 78% of our budget. We also included in the packet in the financials major capital projects worksheet. just as a reminder, two points of information. The Infrastructure Committee is taking a tour of the CEC, the Continuing Education Clinic, next Monday, I believe, this next Monday. And secondly, on Hancock, there's a Hancock groundbreaking on November 8th at 9 a.m., I believe. I think that's right. So no surprises on where we're at on our capital projects. And then last, our emergency reserve balance is $46.7 million. Our preliminary, and again, I'm stressing preliminary estimate of our contingency reserve balance is $499.3 million. In our fiscal year 25 budget, when we did our estimate, we did an estimate and we estimated the balance to be $494 million. So we're at about where we thought we would be, and no surprises there. So all in all, I think we're at where we expected to be, other than the opioid funding coming a little earlier than what we anticipated. Everything else has occurred kind of as we planned, as we completed our estimate for that fiscal year 25 budget. So that concludes our presentation, and I'll turn it back over to the chair.
Thank you, Jeff. Thank you, Nikki, for your presentation. Appreciate it. I also wanted to remind members on page 38 of your packet, it's that standing document about updates on capital project spending, just for your reference, and this will be updated periodically as new information, new expenses arises. Now, is there any questions on the budget? Yes, Manager Valdez?
Jeff, is there some kind of schematic that talks about what the building is going to? Sorry, I apologize. I always forget this. Is there some kind of a schematic as to what services are going to be offered there at the Hancock Center and what the building is going to look like? And I just wanted to know if we could get that.
Yeah,
And-
we'll be happy to forward that to you.
And one more thing, as a result of what is going to go into the Hancock building, if we can kind of have an inventory of other services and other buildings that we have already purchased, and what we're contemplating setting up at that time, so that we can not be duplicating whatever is going to go into the Hancock building from what we're doing, like the CUC, the respite, blah, 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 that kind of thing. If there is an inventory so that we can see what's being offered where.
So,
I just wanted to know if that is available, and if they could get, if somebody's working on that, I would think that they are, that it would be nice if we could get that.
so let me just make sure it takes, so what you're asking about the services that are gonna be provided at Hancock?
Oh,
To
yes,
see, to know
but-
if there's any duplication of those services? Is
No,
that-
basically what I want is looking for a schematic of the building, which, the blueprint for this is what's going to go in this space, this is what's going to go in this space, this is a bathroom, this is an elevator, this is that. I'd like to see that. And in addition to that, the services that are going to be offered at the Hancock building, so that I can see that there is not a duplication of services being offered in other buildings that we had originally talked about.
Okay, so
I guess what I'm just wanting to make sure is that we're cognizant of the efficiency of the expenditure of tax dollars, that's all.
thank you for
But
that.
for us to, as a board, to keep, this is the vision, this is what we're working towards, this is, as it comes online, I can check it off.
Thank you for your question. Two things. I think depending on the location of the services, that's critical, what's needed, because some people who live in specific geographic locations can't access it, so we may need multiple, those services to be offered. And I see Dr. Moran has his hand out.
Excuse me, one thing is that that's just my request. I'm not asking for an evaluation of my request. That's my request. Thank you.
Okay, thank you for that, and maybe we'll follow up on it and see if we have any schematics. And maybe, what's her name? Sorry, who's running our, Stephanie McDonald. Yes, she may have it, sorry. I love you, Stephanie, but she's not here. Oh, there you are, thank you. Dr. Martin?
I distinctly remember them showing us architectural drawings with complete layouts.
Yes.
So that we have that already. It was given to us as a packet previously.
remember
so
that.
Thank you.
Thank you, and maybe we can share that again with Manager Valdez. Thank you. Any further questions, members? I see none.
Dr. Musaitis?
Yes.
Dr. Musaitis, this is Amit.
Yes.
This is Amit.
Do you have any
yes,
questions?
I just wanted to point out, also, I know just with respect to that last request, this has nothing to do with schematics or bathroom locations, but the infrastructure committee meeting, I'm pretty sure Manager Valadez was there. The last one, we were given a really good at-a-glance that had all of the inventory of our properties, anticipated services, anticipated usages of those properties, and also plans for when they may or may not be online. And so I don't know if y'all remember that at a glance, but it was on a 11 by 17 sheet of paper, and it's really excellent in as much as showing a lot of those high level details without us getting into the weeds, of course.
Thank you so much for that. Sorry, I apologize. I missed that meeting. Maybe we can also refer back. Those meetings are recorded and are online as well. Thank you. Now, members, I'm moving along to agenda number 2. Receive a presentation on community.
Okay,
Oh, sorry, Manager Jones. I apologize.
well, that's okay. I think what Manager Valadez is asking for as well, at least I would be interested in, is a layout based upon what we foresee operating out of that facility and how it fits in with our other centers throughout the county, so we can see visually where we have presence. There's going to be a lot of services out of that facility, and it'd be nice to know that there's a central place, there's some in southeast, southwest, so on and so forth. So I think a geographic drawing would be helpful as an overlay, in addition to the information that's already been prepared.
Thank you.
Thank you, Shannon, for understanding my thought process.
And also, the Infrastructure Committee Chair, Manager Amit Matwani, may follow up on that. Maybe within his committee, he can lay out that for all members. So, Amit, I added something to your agenda if you want to consider it. Thank you. Okay, members, in light of our time crunch, I just want us to move along. To agenda number 2, receive a presentation on Community Care Health Center's fiscal year 2024 financial year and estimate. Joy Sloan and Jeff Canotto would be presenting. Members, this agenda only pertains to fiscal year 2024. It's not about operations. It's just the financials for that year. So just wanted to keep that in mind. Thank you.
Thank you, and thanks for the intro, and Joyce Sloan will be doing the presentation. I just wanted to kick off and just say this is a fiscal year 24 year-end estimate, and kind of the same caveat, which is it's an estimate. We're coming, 2.5 weeks after year-end, so these numbers will change again over time, and we'll report back at a later date on what the final audited numbers are.
Thank you, Jeff. I also want to acknowledge the CUC board members and staff for being present here. Welcome. So it's good to have you here. Thank you.
Thank
Welcome,
you.
Jill.
Oh, thank you for having us. I won't read the slides. They're really here for your information. And I will just say that fiscal year 24 has been a very tough year. It's been a tough year for community health centers across the nation, and community care was not left out of that struggle due to Medicaid redetermination and all of the legislative impacts on the 340B program. We did see revenue drop pretty heavily in fiscal year 24, and we saw expenses on the pharmaceutical side go up quite a bit as it cost us more to purchase those drugs. You want to the next slide, please? We did serve more patients than ever in fiscal year 24. Our encounters are over 500,000 for the year. We saw a 10% growth in revenue. We saw 12% growth in encounters. And unfortunately, though, that growth in revenue and growth in encounters did not offset the impact of the Medicaid redetermination that we had. Go on to the next slide, please. More than 50% of our revenue is really based on pharmacy and outside payers. And when we start seeing that instability in those areas, that can really hurt the organization. So as we look at the payer mix, we have done really well with patient encounters, and we've done really well with controlling cost. But we did not really anticipate losing about $10 million in revenue due to the payer mix shift that occurred. Next slide, please. This slide I'm sorry, next slide after this one. I'm sorry. So here's where you can see that in prior years, our revenue per encounter was really climbing as our encounters were climbing. And then we saw this shift happen in fiscal year 24, and we lost about $24 per encounter when that shift occurred. Next slide, please. And we also wanted to bring some perspective when you look at prior years. 2021, our Medicaid visits surpassed our MAP basic visits. And then we saw this shift in 2024 where all of a sudden MAP basic surpassed Medicaid. What an excellent program and support. A lot of community health centers do not have this kind of support for their uninsured patients, and we are certainly blessed that we have that ability. And so as that shift occurred, we worked with Central Health to really help us make sure that we had the coverage that we needed for Travis County uninsured residents who all of a sudden were finding themselves without without Medicaid coverage. We also saw a lot of patients begin to enroll in the ACA Affordable Care Act programs, for which we have staff that are able to do that enrollment. So we did see some commercial insurance increase also as people were dropped off of the Medicaid program. Next slide, please. And as I mentioned, we've seen a lot of impact from the 340B program. That has come under pretty significant legislative challenges. We used to have a margin on our drug cost about 45 to 50%. That's what it cost us from our revenue perspective to buy the drugs. We're seeing that now go up to 62 to 63%. And when you look at fiscal year 2024, that relates to a loss of revenue about $6.6 million that we would have normally had. An example of drug costs are on this slide, where it's just costing us significant more money to purchase these drugs than it did in prior years. That volatility is likely going to continue for a little bit longer, and we're going to continue to see some declining margin on the 340B program. Next slide, please. So we are set to lose about $4 to $6 million in fiscal year 24. We are working through the accruals, as Jeff mentioned, to close out the year. We could end up with an additional about $2 million that would bring us to the $4 million loss. We are looking at cost containment strategies. We want to make sure we do not hurt our ability to recruit team members or harm patient access as we look at that cost containment. And we are trying to be very innovative with reasonable risks and a better balance. And we are focusing very heavily with Central Health, partnering on patient eligibility into multiple different programs. We're also starting to see Medicaid turn back around a little bit. The state fell behind pretty significantly on applications coming in. We're starting to see some of those get processed through. We do expect to see our Medicaid percentage climb a little bit, but it will not return very likely to pre-COVID numbers when patients were kept on Medicaid for an extended period of time. And that is my presentation for the fiscal year 24.
Thank you so much. Appreciate it. I have a question to you. You said you have a deficit, an expected deficit of 4 to 6 million, and I anticipate that would be covered through your reserves that you
Yes.
have on hand.
Yes.
So it's a healthy reserve that you have.
Yes, we have about, we have over 20 million available to help us weather this storm. So it'll bring our days cash on hand down a little bit, but we'll be good. Now, can we continue to sustain losses? No. You know, that's where we've got to get really innovative in what we're doing and how we're structured.
Great, thank you so much. In light of the time, I'm gonna hold off my questions. If there's any members who have any questions? Chair Kitchen?
I'll ask a very short one. And if it's a long answer, you can answer it later. And I think you mentioned this, but I just wanted to confirm that the 4 to 6 million loss has to do with either a lack of payment source for more individuals than anticipated. Is that right? Or is it a difference in the level of payment between the cost for those individuals and what you get paid?
So it's really, when we look at the payer mix, that's where it becomes really important in our world. So for a Medicaid patient, we're currently at $357 per encounter. And so most of our other payers are less than that per encounter. So when you start to see those patients drop off Medicaid, you're seeing that gap between what you would have gotten in revenue and what you're actually getting. And so when we went from about a 36% Medicaid to a 25% Medicaid population, that's where we saw that $10 million drop in revenue.
And that's because Medicaid is cost-based under federal law?
Yes.
Okay. But your other payers are not cost-based?
Correct.
Thank you.
Yeah, thank you. I had a question concerning the pharmacy cost. I mean, it's not my business really, but what negotiating, you gave the example of Volcana going from 90 cents a bottle to 500. I know that, what formulary power do you have in terms of regulating those, in terms of negotiating? I mean, those are very expensive family of drugs. There's a generic version, not of Volcana, but of another one. How does CommunityCare go about that process, setting a formulary and expenses, et cetera?
So I do know, and I can't speak to this in a lot of detail because I'm not the VP of pharmacy, but I do know that when we start to see drug costs like that climb, our VP of pharmacy is very quick with her team to look at what can we move the patients onto that's equivalent, that would not impact the patient, that would help lower that cost. And so they do that constantly, trying to keep the patients on similar medications that don't cost as much or are still kind of considered part of the 340B program so that we get that additional savings.
Thank you.
Any further questions? I see none. Thank you so much for your presentation. Appreciate it. Now, moving along, agenda item number 4, receive and discuss a presentation on the Dell Medical School Health Equity Strategy Report. Members, this agenda item was requested by the board, by board members who asked about the status of the health equity at Dell Medical School. And it was also a topic of discussion by commissioners and community members. So it is really a topic of great attention and also part of our accountability and transparency piece to the Dell Medical School. I want to invite Dr. Jewel Mullen. She's the Associate Dean for Health Equity at UT. Dr. Mullen is a board certified in internal medicine. She previously served as Principal Deputy Assistant Secretary for the Health and Human Department of U.S. Department of Health and Human Services, Commissioner of the Connecticut Department of Health, and the Director of the Bureau of Community Health and Prevention at the Massachusetts Department of Health. She is recognized nationally and internationally as a leader in building effective community-based chronic disease prevention programs and for her commitment to improving individual and population health by strengthening coordination between community, public health, and healthcare systems. And I believe the insights that we will gain this evening will be fruitful for us in how we can engage with the medical school and our partners to move health equity forward. And also just wanted to emphasize that we're here to listen. I know there's a lot of things probably they should not have done, but we're here to learn about where the data is and how we can move along collaboratively along with our CUC members, Central Health, Dell Medical School, because we're all in here for the same mission as improving health for our community and reducing health disparities. So I would respectfully ask us to contain us within that conversation, to be mindful and respectful of folks who are presenting before us. And with that, I am gonna leave the floor, open the floor to Dr. Mullen, and then after that, we can have a conversation and learn how we can move this forward. Thank you so much for coming. Just beforehand, do we have anyone online? No, okay, thank you. Okay. Okay, perfect. Just in case if anyone pops, just let us know. Thank you, Dr. Mullen. Please proceed.
Thank you. And thank you all for inviting me. So I've been rehearsing a commitment to keep my remarks brief enough to allow for good conversation. And so I might look at you and let you give me the signal if I'm getting too close to the 15-minute mark. And we can just stay on, well, we can sit there or stay on the first slide for a minute. I would like to thank so many of you who are here and who have been alongside me in my efforts, in my role since I arrived in Austin and Travis County since 2018. And just personally, I want to say that if for no other reason than I came here drawn to what the goals were for the people of this county, it's only logical that I should be here today and want to give you this update. And I'm especially happy to because so many people have asked me along the way, including many people who aren't here, so what's been happening since you arrived? I also want to give you a little bit of extra background about me so you can understand why I have taken this approach, not just to this presentation, but to the work that I have been working with so many people to advance. So you heard something about where I've worked. I shortened it to over 30, but I will tell you that for close to 40 years in my career, I have worked in efforts to improve access and quality of care for people, for all people, but particularly people who are underserved. That includes starting more than 30 years ago as the director of a resident clinic in New Haven, Connecticut, where both our attending doctors and our resident doctors then routinely assessed how we were doing delivering quality care and managing the acute and chronic conditions of the people who came to us. Followed more than a decade later by my being a medical director of a federally qualified health center lookalike in Springfield, Massachusetts, a health center that was part of an academic health system. There, as the medical director, I was responsible for quality, not just my own, but for the entire health center's performance and for the performance of all of the physicians, residents, because we were a teaching practice, and attendings who practiced and taught there. As part of that, I was also on the medical staff executive committee for the hospital. I chaired the patient care policy committee for our hospital, and that was the committee that made sure that all of our policies that kept us in compliance with the Joint Commission were updated and adhered to. In that role, I also was a member of the health system's ambulatory quality management steering committee. So I used to joke that I called myself the queen of quality, not because it was all about me, but because people would really know that it wasn't just that I had titles, but I really tried to have our work be informed that way. Once I entered Massachusetts state government in 2009, we were just starting to implement mass health reform, which was the blueprint for the Affordable Care Act. In my roles there, I was part of an organization called Mass Health Quality Partners, where we developed quality measures, mostly ambulatory, related to preventive care. And I was also a member of something called the Expert Panel on Performance Measurement that the Secretary of Massachusetts Executive Office of Health and Human Services convened to help determine the quality measures that the state would be using as it implemented health reform. Joyfully, once I became the commissioner of the Connecticut Department of Public Health, I also got to be a regulator because we regulated hospitals. We regulated acute hospitals, long-term care facilities, and we worked closely with federally qualified health centers that we also helped fund on efforts around quality. And then once I got to the federal level at a senior position, it was very logical for me to have conversations with people from HRSA and the Bureau of Primary Care, where we often talked about work that might be done to help better support community health centers that wanted to take advantage of the technical assistance that HRSA might offer them to improve what they were doing. And I know that's a lot, and this presentation's not about me, but oftentimes when people hear my role and they say, so what does an associate dean for health equity do? My approach very much underscores why I have always said the focus of my work is around access to and quality of care. So, since 2018, we have done these things. And when I arrived in September 2018, one of the first things I thought we could do was I could start to learn this community, was to look at what we were doing to afford people language access. So one of the first policy efforts I undertook at the medical school was to develop a language access policy. Not a lot of detail there, but I mention it because we met with people in the community. We worked with Austin Public Health, and the person who was then their consultant for medical interpreting. We even met with people from Texas School for the Deaf to try to get a robust idea of what people really wanted for language access, because communication is such an important part of access and has so much to do with quality. That also helped inform the work that we did, not just inside the medical school, but across a number of stakeholders, where we had internal meetings, and community meetings to start formulating plans to develop a health equity strategy, a Dell Medical School health equity strategy to give us foundational work that we needed to do to move things forward. Our office hired consultants to do that work, and the strategic planning was a coordinated effort that included people from inside the medical school, but leaders from Central Health, leaders from within Ascension, including their chief quality officer at the time, chief medical officers, people who might still be in town in different roles, people who are no longer in town. And it was on December 5th, 2019 that we introduced the first health equity strategy. I think at least 3 of the Central Health Board members were among the 160 plus people who came to Del Med when we announced it. And those of you who I remember being there, if you try to deny it, I'm going to say, I might have even have a picture of you or Shannon Jones on the phone. We launched December. 3 months later, the pandemic hit, and we did what we could to say, how do we keep this work going along the way? And we did. So we had working groups that started to tackle the priorities that we had identified, and there's so much to cover. I know that you have some more background as board members, so I'm not going to go into all of those details. But nothing died. We were deliberate about not having the work die. But in 2022, we reconvened to say, were we right with our original plans? What do we need to tweak? And then we did, again, with a number of very important stakeholders. We updated the strategy and released it exactly 3 years later, December 5th, 2020. 2022. So the consultants who just worked with my office this year really looked at our progress on advancing those strategies, which are very similar to the ones that we had originally devised. All of this work informs the recognition that health equity doesn't just sit in an office. Health equity work doesn't just sit in a health equity office. It's everyone's work, and that you have to do some foundational things to actually advance well-being and to measurably reduce disparities in access, process of care, and outcomes for the people that you take care of. And that we recognized that establishing a culture of health equity starts at the top, but it's everybody's work. So on the next slide, I just have listed out what the strategic priorities were that we highlighted in 2022, and then have asterisks around next to the two that I'm going to focus on most today. Am I doing okay with my time so far? Yes. And I asterisks these two, optimizing healthcare in communities most impacted by health disparities, because ultimately advancing health equity needs to be done measurably and not just with stories. And, having been a public health official, I also used to tell my staff, we can't just measure our impact by whether or not we feel good about the things that we do, but we actually have to measure what we do. And so that was the first part, a real data strategy. And then the second one, because it's also so fundamental and increasingly so, was really taking a look at what our community collaboration has been. I just want to highlight that when we looked at from 2019 to 2022, and thinking about our health equity mission at the medical school, one of the things that we realized was that health equity wasn't actually written into the original mission of the medical school. So that became one of the first things that our strategic planning group said we really want to see happen. And I'm happy to say that when the Del Med strategic plan, Health Starts Here, was released earlier this year, there was language in there around a mission to assure that all people can be as healthy as possible. So we took that as a big win as it showed up in 2024 language. So now I'm going to go to those two priorities and explain a bit about what there's much more detail than we can go into now, but which I want to drive home now, hopefully explaining why these points around data are so important. So with regard to optimizing healthcare and having a data-informed approach to things, there were three elements that the groups that came together with the consultants hired this summer said, we really, really need to get done. One of which was to collect and analyze data to build a common understanding of clinical needs. Data. Establish shared standards around access to quality care. Standards that then we can also work on and measure. And then to have creative partnerships between Dell Medical School, Central Health, and Ascension as we think about the three of us around inpatient care, outpatient care, care transitions. So for each of them, the measures that we defined were not selected by our consultants. They met with most of the Del Med executive leadership team, a number of other leaders, and they spent a day in town and had meetings with groups who were represented, once again, by people from Central Health, Del Med, to really say, what are the meaningful measures we can agree upon together? Because if we can say what those measures are, then we can say, do we actually have data collected so that we can have a baseline that we can track over time to show what our progress is? Are you following me? And so the measures that we identified included, for collecting and analyzing data, there were 10. And as we talked about them, we realized that there was one that we had started working on, and that was around collecting people's information around their social determinants of health and health-related social needs. That there were 2 that were completed, and those related to incorporating information about people's preferred language and their identified sexual orientation and gender identity in the electronic health record. And then there were 10 more that we haven't started that we still have to work on. And that some of those we also can work on in concert with Central Health. But a lot of them also relate to our direct clinical practice around making sure that we are using contemporary standards and collecting all categories that the Office of Management and Budget requires for race and ethnicity data collection, updating it, and then starting to analyze it, looking at access to and quality of care so we can see what the disparities of care are, and then start to make a measurable improvement for wherever we find ourselves to be. But we're at the point now where we still have to establish those baselines. Around shared access, shared standards for access to quality care, the groups that met, and we had Central Health and Dell Medical School leaders responsible for this work in the room simultaneously, that they started to talk about what it would be to together start to work on those. And we had already made some progress on a few of them that I can tell you that we had started with some of the partnerships that we've had improving access to and quality of ophthalmology care, for example. And then the third was creative partnerships between Dell Medical School, Central Health, and Ascension, where right now we could say we've started some collaboration with Central Health and Dell Med around working under Desmar Walk's leadership and implementation of Watershed. And then the conversations we've been having around respite care and care to expand specialty, availability of specialty practice. I can go on to the community piece because I know I must not have but so much time left. Okay.
So Dr. Mullen, there's not much,
Yep.
I just want to
And
open
so
it.
what I would say is we drove home the importance of community collaboration primarily because systems improvement has to be not just informed by what community wants, but really now being at a point where we have dynamic, ongoing community engagement. So we established some specific measures around what that should look like. The consultants have recommended, just for these 2 priorities, that we continue and enhance data collection. And they put up a couple of specific recommendations there. And they wrote a couple of specific recommendations around exactly how to meaningfully engage communities. If we go on to the next slide, I will tell you then that some of my recommended next steps will be for all of us to incorporate the feedback that we and our office is prepared, if necessary, to bring consultants back to actually stand up a dashboard and then establish a regular cadence for measuring our measurement and updating it, and then to really put a group together to establish a framework for meaningful community engagement. Next slide is just a reminder that even here, we don't have to reinvent the wheel. So I just included links to what you can find from Parkland Health and Harris Health, where when you go on their websites, you can see their clear statements around their commitment to quality, to being high reliability organizations, and to using data-driven approaches to reduce disparities. It's right here. It's right here. We don't have to do it. And then I'm just going to end with this. I couldn't figure out, there's, I think, one more slide. I couldn't figure out how it was that we ended up releasing both strategies on December 5th and what the meaning of a December 5th might be. So I spent some time looking at what happened on December 5th. And what I will most come up with is that it's the day that Nelson Mandela died in 2013. So I end with his quote, "It always seems impossible until it's done." when I told people I took this job, they told me, good luck, it's impossible. I'll stop there.
Thank you so much. Appreciate it. Appreciate the presentation and for your courage as well, coming forward, because this is not easy for you to come and speak upon this matter that it's a priority for us, a priority for everyone, every taxpayer as well, and every patient that is in our community. So Dr. Mullen, I have a question for you. I know, like personally, I know I'm going to open the floor, but some concerns that I have based on some of the projects and measures that have not even started, some of the data that is not being collected, simple data as race and ethnicity data, that's simple, that can really, so I'm just going to leave. How can we get to where we need to be, and what would it take? I know the school has been in inception for several years, and what matters to us is that our community and our patients are receiving high, equitable health care and health. I also always will speak on that term. So to me, that is very concerning that there are several projects that have not been implemented since. So I would hope, and you don't have to answer it right now, but I just want to reiterate and emphasize this is a concern for me, and I can imagine for other members as well. So I'm going to leave my other comments right now. I'm going to open the floor. I'm going to go here.
Would you like me to respond, though?
Yeah, please.
So, I understand. I wholly understand. And I could probably go through a long list of reasons. It's so easy to talk about what you aspire to, and sometimes people don't realize the expertise that's really needed to lead the actual visionary and technical work that has to be done. And on top of that, there's been so much attention paid to addressing social determinants of health to advance health equity that many healthcare providers haven't paid sufficient attention to what they're responsible for around healthcare equity, which is related, but when it comes to what you do clinically and what your system does, then it's what it's what you do in your medical setting that you have control over. And so, I think we and this community, and I'm not saying this community to sort of, like, I represent Delmed today and I'm getting us off the hook. We all have to really pay more attention to health care equity and these measurable changes around how we deliver health care to everyone and make sure everyone is cared for. And that's why it's so important to be able to own what we haven't done, but then take the next step, which is to say, you have to start, and you can't wait until you're set up to be able to do it all before you can do anything. That's my opinion.
Thank you. I appreciate that response. Manager Jones, are you online?
Yes, I'm online. I've been interested. Thanks very much, Dr. Mullen. Sorry I'm not there to see you, but really appreciate your presentation. I just sort of have a bigger question. I agree with everything you said with regards to healthcare equity as well as health equity. However, the hospital district, at least Travis County Hospital District, has invested specific dollar amount into the delivery of care. So the question I guess I ask for you, and I don't know if you can answer it or the leadership there at Dell can answer, is what would happen if we had not done this and decided to use those dollars in other ways? Would that still be an issue for a Dell Medical School of equity for all people, or just for those who benefited from the medical school and the hospital? And I don't know if you can answer that, but hopefully you get a feel for what I'm trying to get at.
I'm trying to track it, but I could answer a question different from the one you're asking me. Can you break it down for me a little bit more?
Well, for instance, had we not invested $35 million over these $35 million a year for these many years and used it for our health, our entity, what would Dell Medical School have done towards addressing issues, or the state, let me say that, done towards addressing issues of not necessarily disparities, but healthcare for indigents in the community?
So no, I can't answer the question. And, I've been among all of us enough to know that, I don't think anybody's saying nothing has happened. And so I can't answer your specific question. I think I can mostly, maybe other people can, even people who aren't in this room. But I'm trying to keep from working in my role of influence, but not absolute authority, hoping that if nothing else, this presentation helps all of us feel called to make what happens next be different from what's happened before, so that we can get it done.
Thank you for that. Appreciate it. Manager May? Thank you, Manager Jones, just for... Manager May, do you have any questions?
I applaud you for your work. It is indeed necessary work, and the fact that you came to Texas to really lay the groundwork for it is critical, and from the community, we want to thank you for that. I don't have any questions, like some of my other colleagues. Perhaps I have some concerns, but I'm not even going to put them out at this point because that would just spoil the presentation, and I love what you had to say. Thank you.
Thank you, Manager May. Manager
Thank you.
Mawani?
Thanks, Chair. Thank you, Dr. Mellon. Certainly want to echo Manager May's comments around really appreciating the ethic of and the essence of what you're bringing to us. Two questions. The first of which is, do you feel like you have the momentum now, as you give us this presentation and we discuss sort of, if not course correction, at least course adaptation moving forward, do you feel like you have the momentum or a wake to operate in, if anything, of momentum to kind of move forward on achieving sort of those strategic goals? That's the first question. And then the second question is, knowing that Dean Lucanetti is one of the leading authorities on artificial intelligence, particularly in the healthcare environment, are there thoughts or discussions of incorporating equity, particularly through the lens of artificial intelligence, which, as we know, those learning models are pretty damn biased? Is there a notion of in possibly folding that in, or has that been discussed when it comes to overall equity? Thanks.
Thank you.
I told myself that after this presentation, as the days go by, I'll have a better sense of what the momentum is like, because it's everybody's work, right? And I mean, I'm in a position most people think is unworkable, but which I love being in, which is why I have a role with Central Health, a role with Ascension, and a role with Del Med. And it's all because I focus on this stuff that everybody thinks about, all of us think about, but with different ways and different incentives. So the question is whether or not there's enough collaborative momentum, because it takes everyone, is number one, that's sustained, and that in the midst of everybody's priorities can fit it in. Now, I swore I wouldn't do testimonials for anyone, but I sit on Central Health's quality committee, and I know what's going on there. Right, Dr. Schulze? Sorry, but I called you out. And so there's stuff, but there's a lot. And I've worked in health centers. It's hard, but I think things are evolving there too. How do they say it? We have opportunity, and it's only up to us. In terms of artificial intelligence, it's the year of AI, which means it could also be the year of more biased information. And the best way for us to make sure that doesn't happen is, before we go running off, chasing the new things, is to be really good about this data collection we haven't done yet, so that our inputs aren't that flawed.
Thank you for that. Thank you, Management Wani. Chair Kitchen?
Thank you so much for being here. I would echo what everyone has said so far. We really appreciate this. And it's a very helpful follow-up to the presentation that was made to us, a while back on this subject. So I have 3 basic questions. The first one is, will you meet with us again on a regular basis to let us know progress? I find that what you've shared with us is concrete in the sense that you have let us know how many have been completed, what is ongoing, and what has not been started. I would like to keep an eye on that. And so I would leave that to our chair here to think about when, but I would like to have you come back and report. You and whoever is appropriate that you're working with. I mean, you mentioned that that collaborative momentum is important, so I would invite you to bring with you whoever else needs to be part of that collaboration. I would also invite you to name who you need help from. So that was my first question, actually, which was more just a request.
Well, and so may I just
follow
say yes? And I was going to say yes before you finished the question anyway.
Okay.
But I will also tell you that the consultants that worked with us are excellent. And I'm in a position to also have them work with our collaborative further if that is desired or if you need more information.
Okay.
And also that was an action plan, just to let you know.
Excellent.
Thank you.
Okay, I figured you'd already done that. So anyway, so my next question then is, I think you answered. Do you have the resources that are needed to carry out these 4 recommendations?
Right now I do.
You do.
So far, yes.
Okay, you will let us know if that changes, right? Okay, and then the last question is, what do you need us to do? Are we sitting at the table with you and collaborating, or do you need more from us? And that may be a question for Dr. Lee, but I mean, I know that we're trying to participate, but is there more that we can do?
Well, there might be.
Okay,
And I think that's why I included the quotes from both Harris and Parkland.
uh-huh,
I think so many people have great ideas, right? And I talked about working under the Executive Office of Health and Human Services in Massachusetts. There's no shame in learning from people who have been doing things longer than we have at an organizational level and at a board level. So I'll let you consider that.
okay. Well, I would like to know some specifics, and maybe that's an action item for Dr. Lee to help us understand what else we can do. And I would just invite you to make an ask if there's something specific that we can do. Thank you, Chair.
Thank you. Dr. Princeton?
So as you continue this work, what is your next step?
We left the number of to be done in the fall of 2024 items related to data collection, reconvening with our colleagues at UT Health Austin. I think for the sake of efficiency, we will now have an opportunity to revisit some of the plans that working groups that Dr. Lee and Dr. Lucanetti thought about DelMed and Central Health co-leading, and see whether or not we can put an even sharper focus on some of these next steps. So that would be one of the first things that I would really look at, rather than thinking we need to stand up something else. Because standing up a new thing that is really about our core work doesn't necessarily mean that we're going to get that core work done.
Thank you, Dr. Princeton. Dr. Martin?
Thank you, Dr. Mullen, for coming. You mentioned the Parkland and Harris County system. I trained in the Parkland system. And I'm wondering, what is I don't know how much you've looked at them, if they're worth emulating to sort of more rapidly cut to the chase to some extent, since they've been doing, Parkland's been in practice for 70 plus years, 90 years maybe, Harris County longer. not as hospital districts, but as medical schools. And I'm wondering if you've assessed that and the ability to work with them, I guess, is sort of in a way speed things up to some extent, which is what I'm kind of hearing from the rest of the board members.
I would be overstepping my expertise to say work with them. Every system is unique. So there might be elements to emulate around fundamentals, collecting data, analyzing data, putting together the right leadership with the right expertise for quality and performance improvement across systems to make sure that happens. Because as integrated systems, they have to have buy-in for data sharing and for data collection. But I would also leave that to Dr. Lee and others to figure out what works. And maybe also, similarly, when we talk about board development, how their board is different from yours as well.
Well, I guess what I'm getting at, I mean, if there's a metric of success, to learn from them and apply it to our system, which is different, but I think the aspirations of Delmet are similar to the other ones. And I guess I would ask if we could ask of you to maybe get back with us about any collaborative effects you might have with them.
Okay.
Thank you.
Thank you, Dr. Martin. Manager Valadez.
Thank you, Dr. Mullen, for being here. Keep up the good work, and don't ever let your voice be silenced.
Thank you.
Regardless of what you're up against, even if it's sometimes us, okay? Because I would say, I'll give you I'll support the $35 million going to setting this up, and let's cut out the other crap. But with respect to that, understanding the need to look at health equity in this time of crisis for minorities and people in poverty. I don't see it getting much better looking at an election that can go one way or the other. And the fact that many services have not been offered. So that is core to the continued state of healthcare for our poverty population. And because there are those in administrative positions that could very easily have just tweaked admission documents to gather the data that was necessary in order to get the access to numbers, we're still there, okay? And now what they want us to do, or what they want the hospitals to do, is ask me whether or not I'm a dadgum citizen in order to determine whether or not I get services. And that's even, that's a human rights violation as far as I'm concerned. But I want to know, in light of all of that, you're dealing with a system that's one of the most racist, an institutional system that's one of the most racist, the University of Texas system. And how are you and your colleagues ever going to be able to get those at the top, the elites, and the elitists, to understand that that is exactly what they need to focus on in order to equalize the state of healthcare for all people in our community? You know what you're dealing with. We know what you're dealing with. But what can be done by you and your, I would think, relatively few colleagues that already know what the University of Texas does to anybody that speaks against them? It's the same thing that administrations and institutions do for anybody that speaks against them.
So
Thank you, Manager
it's a
Valadez.
perfect question. It might not be a perfect answer, but it's a really logical one. And your question could make some people think there's no answer, but there is. And this is my version of it. My version is everything that you just cited, it is not an excuse
for being able to do the work or not doing the work that the Joint Commission, the National Committee on Quality Assurance, the Centers for Medicare and Medicaid Services, and payers all look for healthcare deliverers to do to provide accessible, high-quality care. That's a constant across politics. And within that, even in Texas, even at the local level and at the county level and at the state level, there's work being done every day in those contexts. And a lot of people who are working on it. But fundamentally, standards, measures, and I mean, most places, every place I've worked has aspired to be accredited, an accredited organization. And you become accredited by doing this fundamental work.
Well, thank you for that fundamental work. I appreciate this conversation can go longer and longer. I know that there's a lot of interest. Now, in light of time, what I'm asking as the chair of the committee, that you come and report back to us on that report and the implementation of those strategies. I'm thinking at least twice before the next budget cycle. I think that's reasonable. The next 3 months or so for you to come, because I think that will give you ample time to at least have some preliminary data and see how things have evolved. And are you all in agreement with that time frame?
Yes.
So I don't see any objections.
I only would like to say one thing.
Yes?
You were talking about the programs, the measures that had been started, not been started, that were left on the table. Can you provide that information to us as to what measures you are exactly talking about per item?
Yeah.
We want the specifics. Thank you.
Yeah, and there's some material in the backup, Manager Bell. There isn't, okay. So, Dr. Mullen, we can provide that information, and we will see you back in 3 months, that you would have, so we'll follow up and appreciate it. And on behalf of the board, we appreciate you, and also on behalf of the community and everyone else, thank you for the work you do. Appreciate it. Oh, Dr. Lee, if you would like, sorry, I just want to acknowledge Dr. Lee. Go ahead, please.
Thanks, Chairman Satif. Dr. Mullen, thank you. Thank you for your voice, your leadership, your welcome to the community. Appreciate your speaking truth, motivating us. I want to actually offer a point of hope and optimism. We've talked about the problem to solve, that patients that we serve are dying 10 to 20 years earlier before their time, that the cumulative economic impact of health disparities in Travis County comes to at least $1.1 billion every year, and that's probably a low-end estimate, and that is the problem to solve. When we talk about the health equity gap, it is the people's life expectancies and the enormous economic impact and all the underpinnings of that. But the reason why I'm hopeful is I think the solution to a lot of that is around access. Access to the high quality care that patients need and deserve where and when they need it. And to provide that access and that continuity of care requires systems and partnerships. And as I've come to understand our systems and our opportunities, the fact that we are entrusted with tax revenue from the people of Travis County, connected to our other taxing entities, interconnected, that we provide payment for services through MAP, Basic, and Sendero. We can shape the financial incentives. We employ directly, and we provide care directly. That we have our Sendero health plan partners here, we have our CommunityCare partners here, and together, if we can knit end-to-end, birth to death, pre-hospital, acute care, post-hospital, mental health care, housing for health care, and knit this together, we can solve for the fragmentation throughout the safety nets around the country that really lead to a great deal of the suffering and avoidable harm that we see. And so I believe our end of this work is around building the structures, the equitable, the fair, the effective, and the collaborative structures that enable people to get the access they need, and honored to get to do that together. I think it's a nice segue into the series of retreats that we're about to have as a board, And this is a very important year for us as we think together about the role that we have to play in building the safety net that delivers the care that our community deserves.
Thank you, Dr. Lee. And something I just wanted to put a nudge, and I know some folks are listening, may not be here, but we also, as a board, expect a seat at the table for our patients with the building of the new hospital that we expect, we're talking about access to care, high quality access. So we expect that there's some, our patients will have access to it. And we expect also our patients to have access to the cancer center, to MD Anderson. Also, we want to have a seat at the table with the planning phase because our patients deserve high quality, equitable care. With that, I will end. Thank you so much. I appreciate you. Now, moving on, members. I'm sorry, we were beyond. Thank you. I'm sorry, but this was a much needed presentation. Now, members, moving on to agenda item number 5, discuss and take appropriate action on an update regarding Sendero Health Plans, Inc. financials and proposed business strategies. And I announce that the committee is convening closed session to discuss agenda item 5 under Texas Government Code 551.085, governing board of certain providers of healthcare services under Texas Government Code 551.071, consultation with attorney. So members, at this time, we are in closed session, so I'll give at least 5 minutes for us to transition. Thank you. Okay, are we ready? Okay, do we have a quorum? Okay, perfect. Thank you so much. Members, we're out of closed session. Now we're in open session, and it is October 23rd, 2024, and the current time is 5:57. I have a motion on the table for agenda item 5. Anyone? Manager Mawani, can you make the motion? It's on here. Do you have a copy? I have it right here. Here,
I move that the committee recommend that the board adopt a resolution authorizing the formation of a new insurance subsidiary of Sendero Health Plans, Inc., as discussed in closed session.
thank you. And a second by Manager Valdez. So we have a motion on the table and a second. Members, Manager Jones, do you want to appear so you can count your vote? All in favor? Any abstentions?
Could I speak to my abstention?
Sure.
Okay, I'll be abstaining. I need further information, and I've been out of pocket, so I haven't had the opportunity.
Yeah, you were enjoying your time away
Yes.
from us here for the past 3 weeks.
In other words, it's my own fault, so to speak. But anyway, and so I've requested information related to the net financial impact, and so I will need that information before I
Thank
can.
you.
So
Thank
that's
you, Chair.
why I'm abstaining.
Thank you, understood. Manager Jones, did we capture your vote?
No, I'm abstaining as well, for some
Okay,
of the same reason that the chair did as well.
Thank you, Manager Jones. So we have 2 abstentions and Manager May is not present. The motion carries. Thank you all so much. Now moving on to agenda item number 6, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, November 13th, 2024 at 3? Why is it 3? Oh, okay. Just want to make sure. I cannot make a 3 p.m. Thank you. Sorry, Dr. Moran. So it's at 3 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I am ready to accept a motion for adjournment. Motion adjourned by Manager Brinson.
Yes.
Seconded by Manager Valdez. All in favor? Aye. We're adjourned.
Okay, managers, I'm going to move us directly into our Board of Managers meeting, and then we'll come back to the Executive Committee meeting after that. So in order to get us closer to the time that we need to with our public hearing. So good evening. Today is October 23rd, and it is 5:59. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. This evening's here. So the first item that we have is a public hearing. This evening's hearing is the official public hearing for the annual LPPF rate setting required by the Health and Safety Code. Notice of this evening's public hearing was published as required by statute. The hearing will begin with staff's presentation of the proposed annual mandatory payment rate. At the conclusion of the presentation, we will invite comments from the public. To make comments during the public hearing, members of the public must either be physically present or have registered via the online form. We will alternate between speakers who are on site and those who have joined the public hearing virtually. So first, we're taking up item number 1, which is to receive public comment on the proposed mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2025 under the Local Healthcare Provider Participation Program in Travis County, and how the revenue derived from those payments is to be spent as required by Texas Health and Safety Code, Section 298E.101, and I think Kathy Coburn will be presenting. Thank you, Kathy.
Thank you. I'm Katie Coburn, actually, but it's all.
Did I say Kathy? I'm
Yeah,
sorry.
that's fine.
It
It wasn't
says-
written anywhere. I'm impressed you got that far, to be
I
honest.
know you're Katie.
I know
you're Katie.
Well, it's that time of year again. We are here to consider the FY25 mandatory payment rate in our LPPF program. just as a reminder, and for public who are listening in tonight, the Local Provider Participation Fund is our way to generate local funding that we can then use on behalf of private hospitals in our community to leverage federal funding. You all do this by assessing a mandatory payment rate on inpatient hospitals in Travis County. That rate is a uniform percentage set across all inpatient hospitals. Central Health serves as the administrator and acts in a fiduciary capacity with those dollars, holding them separately from Central Health general funds and using them only for legally allowable uses, which is primarily to access federal supplemental payments. Also, $150,000 goes to Central Health for administrative expenses. This year, we are again recommending that the board approve a 6% mandatory payment rate, which is the maximum allowed by law, to draw down the maximum amount of federal funds available to us. That's it.
We're going to move to public comment. Are there any, I don't see any questions from the board. Okay, we'll move on to public comment. So Yesenia Ramos of the Central Health Communication Department will briefly cover the guidelines for the public hearing portion of the meeting and will then call upon members of the public to comment.
Thank you, Chair Kitchen. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit to ensure the efficiency of the meeting. Once we let speakers know they've reached their limit, we'll allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. For this specific LPPF public hearing, we received 2 submissions. One needed to drop off from the call, Jeronimo Rodriguez with Ascension, Texas. So I will call Corbin Pefanes from Adelanto Healthcare Ventures, who is speaking virtually.
Hey there. Good evening, everybody. Can you hear me?
Yes.
I'd like to say thank you for the opportunity to speak with you all this evening. My name is Corbin Pefanes. I'm a consultant with Adelanto Healthcare Ventures. HCV represents a majority of the private hospitals within Travis County. And on behalf of those hospitals, I'd like to voice 6% for the voice support for the 6% rate that has been proposed and express gratitude to Central Health for their efforts in administering the LPPF. I know we have a lot of asks of you guys, and it's a pleasure to work hand in hand with you. That's all I've got.
Thank you, Corbin.
Thank you.
And I believe those were the only 2 signed up for the LPPF public hearing, but I will make this announcement if anybody from the public communication side signed up for this, and I may have missed anybody. Please unmute.
Again, this is just for the public hearing side.
Yes. Okay, I think those were the only 2.
Okay. All right, thank you. All right, I'm now ready to accept a motion to close the public hearing. Motion from Manager Valadez, second from Manager Matwani. All in favor?
Aye.
Okay. So we'll now proceed to the public communication part of our Board of Managers meeting. So Yesenia, I believe we do have a number of people signed up for public communication. We also have our mission moment, I believe, this time. So we'll begin, let's begin, and Yesenia, you may have it in this order, but let's begin with our, do you have our folks from the National Disability Employment Association month
Yes.
first? Yeah, okay.
I have Kent Kaziski, who's there in person.
Okay.
And he is our Director of Workforce Advocacy.
Okay. Thank you for being here with us.
Thank you, Brian.
hi again. There's a slide for y'all, so yeah. Thank you. Great. Again, hi, board managers. Again, Ken Kaczynski, Director of Workforce Advocacy or Diversity, Equity, Inclusion here for our system. I'm happy here to be representing our DEI Council as well as all employees. Before I get to our main topic in October, I want to recognize this past month has been very busy for us all. Closing out Hispanic Heritage Month and recognizing many clinical campaigns and staff members through Breast Cancer Awareness Month, National Pharmacy Week, Medical Assistant Recognition Week, Respiratory Care Week. But once again, I want to highlight our partners through Wellbeing Communications who have been doing a great job recognizing all of these and tying our messages together for our clients and our employees alike. Specifically for the Diversity, Equity, Inclusion Council, we are focusing on National Disability Employment Awareness Month, or NDEAM, as I'll call it for the rest of the time in 2024. This year's theme was Access to Good Jobs for All, where we decided to focus on an internal campaign to dispel stigmas around visible and invisible disabilities in the workforce. Particularly, we were highlighting and explaining to leaders and to staff around navigating accommodations and resources, especially in the intersection between disabilities and mental health. Yesterday, actually, we hosted a system-wide webinar called Disability in its Spectrum, where all employees were able to learn about different types of disabilities, learn about the difference between visible and invisible disabilities. We provided resources available within our system and also externally through government programs. We talked about individual lived experiences and support systems for individuals with disabilities, and more importantly, how to be an ally and to continue this work moving forward. I really want to highlight, and you can go to the next slide, all of the panelists and the partners who kind of came together for this, including our HR department, community outreach, Central Health and Community Care behavioral health teams, and our Central Health eligibility team who came together for this work. Specifically by name, Neha Srivastava, Christian Nelson, Dr. Bree Wanamaker, Kat Conte, Heather Gauze, Misty Laborde, and Becca Klein. Additionally, we were really excited that the webinar happened yesterday and it's recorded for all employees. But you'll see an image here. We also worked with our employees in our support systems to create a guide on how to continuing to seek support, provide support, and continue the education beyond just that one webinar for all employees for the rest of the year and beyond. And this has already been adopted by our leave and accommodations team and is being integrated to communications for all of our employees. So just want to highlight some of the work happening for the Diversity, Equity, Inclusion Council. And as always, if you ever have any input or advice about other work, other significant recognitions, feel free to let us know how we can engage with you and your spheres of influence. So thank you today.
Thank you for being with us.
Anytime.
Appreciate it.
Thank you, Kent. Up next.
Just a minute, Yesenia, go ahead.
Thank you so much. In terms of the highlighting the equity, I don't, in Central Health, I'm not sure if anyone is going to speak on that behalf, but on October 12th, our group from Central Health and I presented at the Texas Health, Healthier Texas Summit about the work that's being done here at Central Health. It was well received from all across, so I just wanted to share that as well. Thank you.
Thank you. Okay, Yesenia, you can proceed now.
Thank you, Chair Kitchen. Up next, we have Robin Kardapur, who is joining us virtually. Robin, are you?
Hello.
Oh, perfect.
Yes. Hi, can you hear me?
Yes. Mm-hmm.
Well, actually, thank you so much for giving me this chance to speak. A couple of comments. I'm a primary care doctor in community care for the past 8 years. So a couple of issues, if you don't mind, I'm just going to speak and you can stop me anytime. So the concern is that we all know that we live in an unfair world. 87% of women in Sudan have suffered female genital mutilation. Every day in Afghanistan, Yemen, Saudi, Iran, Nigeria, and many other countries, people are executed for consensual same-sex activity. Not everybody in this world is aware that what practices are considered discrimination. They just think this is the way it should be. The information suppression that exists throughout the world keeps the status quo. The term national pride keeps Chinese workers with extremely low pay and Saudis women in their house. 14% of Texans have Medicaid compared to national average of 21%. Since Medicaid expansion of 2014, Maine, Nebraska, Idaho, Utah, Missouri, Oklahoma, and finally in 2022, South Dakota have joined Medicaid expansion through people's decision in ballot boxes. Clearly, this is not a red or blue issue. It's a human rights decision that affects millions of Texans. It also affects middle class since they pay so much property tax to support entities like Central Health. It is time to stop sugarcoating with useless terms like health equity and advocate for putting Medicaid expansion on balance. The number two is that majority of my patients are hardworking Latinos that you know them when your contractor repairs your house or landscaping company fixes your backyard, or maybe the cleaning lady in your hotel or babysitter. They are not married to a billionaire to get legal status or educated to get any education visa, J1, H1, or O. In 2 weeks, some people might say they have to leave. Why are you giving them healthcare when even Americans can't get it? Should these people be worried about Central Health cutting them off? Or worse, as a government agency, report them to immigration? Who will protect them? And number three is that as a community care employees are getting their paychecks from Central Health. So if we are part of Central Health, there should be some transparency about the benefits that Central Health employees have, which community care employees have. And I think all the hardworking medical assistants and employees of community care deserve that in a place that there's really no collective bargaining for employees. They should have it. Thank you.
Thank you.
Thank you. Up next, we have Melissa Shearer, who's joining us virtually. I do not see Melissa online. Melissa, if you're online, can you please unmute? Okay, up next we have Community Care Board Director Sendero Jefferson, who's joining us in person.
Does that work? Yeah. Okay, good afternoon, Board of Managers. I'm Sendero Jefferson, one of your 2 appointees to the Community Care Board of Directors. When I expressed interest in the CUC board to you about 1.5 years ago, I explained why I was willing to serve. I pointed out that I was seeing retirement on the horizon and I was looking for an opportunity to use my professional knowledge and expertise for causes that benefit our community and society as a whole. Healthcare for all was an easy cause to sign up for. Payment for me is doing the right thing for the right reasons, and I suspect you all have agreed to be on this board for similar reasons. Like you, I have served on numerous boards as a volunteer. I have also served as legal counsel to several governing boards throughout my professional career, many of them governmental entities, governing boards. So I can say without a doubt that I have seen nothing but consummate professionalism and competence among CUC leadership and staff, including Jason Fournier. That is why I remain deeply frustrated and astounded that whatever issues Central Health had or still has with CUC, that they were not brought to the CUC board's attention first. No organization is perfect. No person is perfect. The CUC board, however, can handle candid, evidence-based criticism. But the unilateral interventions that have occurred since September 4th by Central Health have been destabilizing and completely antithetical to the collaborative model we have been under since 2007. I worry about our staff. Our organizations have the opportunity to course correct, to get us on the path of collaborative problem solving and charting a new future for meeting the needs of the uninsured and underinsured. Let's keep the mediation date scheduled for next week. Delay is not our friend. Not if we're serious about repairing our joint co-applicant relationship. I received an email from a friend who's with an association, and at this email signature block, there was a maxim that comes from their organization. It's called Fundamental Number 1, Act with Integrity. Demonstrate doing the right thing in all your actions and all your decisions, especially when no one is looking. Acknowledge and own your mistakes, clean them up, and make appropriate corrections. Integrity is not a part-time job. The CEC board can handle candid, evidence-based problem resolution. And I ask that you trust us to do that, and I hope that you will be at the mediation, a couple of board members or two, less than a quorum, obviously, next week.
So, Sedora, Ms. Jefferson, you and I have worked together for a long time, or actually we've known each other for a long time.
We have and worked together, right?
Yeah, I was really appreciative. One of the first opportunities I had when I got on this board was to vote for you to be on the CEC board. So I appreciate you coming today. I hear your message, and I thank you for coming to speak to us, and I thank you for your service.
Thank you, and I'm happy to talk to the board, a subset of the board,
Sure.
whatever's appropriate at any time. I feel like that's my fiduciary duty to CUC.
Okay, thank you. Okay, Yesenia, who do we have next?
Up next, we have CommunityCare Board Director Kimberly Johnson.
Good afternoon. For those of you who do not know me, my name is Kimberly Johnson, and I sit on the board of CommunityCare. I'm here today to talk about my concern about what is happening between Central Health and CommunityCare. In a word, trust, the lack of it. The broken part of trust. Some of you I've met, you have shaken my hand, you have asked me how I am, how I'm doing. We have sat at a table, we've had discussions, and yet you have broken the trust. And then, on the other flip side of that, I am Kimberly Johnson, the patient. And how can you look me in my face, shake my hand, ask me how I'm doing, and for what you have done, you have broken that trust, but still expect me, the patient, to trust you with my health care? How dare you? How dare you insult me? Because if you can do Kimberly, the board member, who you know, who you sat at a table with, who you have shaken your hand, said that I hear you and treat me the way you do, how in the world can I expect you do any more for me as a patient? Why would I want to trust you? I'm having a hard time dealing with that. I'm having a hard time shaking hands and smiling. I'm having a very hard time in trusting you with the most important thing that I have, other than my child, is my health. So make no mistake, I sit at this table and I sit before you for all the other mothers and children and fathers and people who have no clue about a central health board, about a community care board. All they know they want is a great health care center. People that they can trust. People
30
I
seconds.
can trust. That's what I want.
Thank you for being here with us. We appreciate hearing from you.
Up next, we have Central Health President and CEO Pat Lee.
Thank you, managers and colleagues. I'm here with the opportunity to share a brief window on a recent delegation from the City of Austin to the City of Denver to learn about the mayor's commitment there to end unsheltered homelessness. So in the brief 3 minutes, I just want to acknowledge the leadership of David Gray, who convened this delegation on behalf of the Homeless Strategy Office. There were 30 members from Austin that went. So David Gray and his team, Assistant City Manager Stephanie Hayden Howard, Jamie May leading the Housing Department for the city, our city councilors who lead our Public Health Committee, Councilmember Fuentes, Velasquez, Quadri, and Ryan Alter. ECHO was present, Matt Malika and his team, and then our County Commissioner, Ann Howard, and Central Health. So the first thing I would share is it was remarkable to see 30 members from Austin across all of these areas in Denver focusing on this issue. It was impressive to see what a focused mayor and a strong mayoral system. City and County of Denver are one. There is no city manager, so the mayor functions as the executive for city and county. They have reduced families experiencing homelessness by about 80+%. When you walk around downtown, there are no more large encampments. There used to be encampments instead of a sweeping from block to block practice. That's all gone. And the operations have been quite impressive. One thing that really spoke to me was a policy of no referrals, meaning that when a complex case manager met an unhoused patient, if they were willing, would drive that person directly to their MAT appointment, observe them getting their first MAT shot, and then take them straight to the recovery housing where they could then continue their recovery. They didn't go back to the street. Thought that was very impressive. We got a chance to visit the Colorado Coalition of the Homeless and their headquarters at the Stout Street Health Center, where we saw a healthcare for the homeless FQHC that spent about $50 million a year on direct care services and $50 million a year on housing. They house over 4,000 families every night in Denver, and their main headquarters was a large Southeast Health and Wellness Center sized facility next to a 9-story tower. The first 3 floors were medical respite. The top 6 floors were permanent supportive housing, and they had another 300, 400 units of housing around the building, the area, and interconnected with many other services. Denver is running unsheltered homelessness as a state of emergency, so they have an emergency operations center that meets twice a day like we did through COVID. Inspiring. And I believe I speak on behalf of our 30-member delegation, which showed that we were inspired by that.
30
and we were
seconds.
asking the question, what could we do here? And I want to have a special shout out to all my colleagues, and in particular, I think, to Matt Malika and our ECHO colleagues for their outreach immediately upon return. I'm excited about what we can do together to bring housing and health together. So just wanted to share that report with all of you. Thank you.
Thank you, Dr. Lee. For everyone else who's wondering why Dr. Lee is speaking to us this way, we discovered a flaw in our agendas, And for future reference, we're going to be adding an agenda item to every meeting that's a report out from our CEO, so that we're not in a situation where he has to report out in 3 minutes. So thank you for this today.
Thank you.
Okay, Yesenia, you want to go on to our
Yes.
next person?
Yes, Chair Kitchen, we have, the rest of our speakers are, Central Health Board of Managers. And we do have a mission moment that I think is here in person with us and, needs to get going. Is it okay if we bring her up first?
Let's take our mission moment first, yes.
Perfect. Maria Mendoza Rodriguez, if you could please, come up. And Maria's our supportive and palliative care nurse navigator at Central Health.
Thank you. Hi, my name is Maria, and I, along with our supportive and palliative team, have had the honor of being a small part of Mr. Nelson, Steve, as he likes us to call him, in his healthcare journey.
Could you get a little closer to
sure.
the,
Are y'all going to show the video of him too? We can. Is there video? I think they wanted to show the video first so you can see him.
When we first met Steve, he was our very first palliative care patient. And he was just very warm, had a very warm smile. That's what I remember about him. He was just very inspirational because he just knew, despite his diagnosis and prognosis, that he was going to get through it.
Well, when I first visited with Dr. Owens and her staff, I knew right away that I was in good hands and that I was going to be taken care of. And they set the bar.
So when he came, he was carrying a lot as far as just with his diagnosis and not being able to work. And so there were a lot of barriers that he had that he was concerned about. And so, of course, with cancer, that's a financial strain. So he was worried about how he was going to make ends meet.
Any issues, my pain, they've taken care of my pain. Any other issues that came up, they've addressed, and they're right on it.
He has been able to meet his health goal as far as being able to be done with chemo. During that time, nausea and pain were some of the biggest factors for him as far as symptom management. That is something our providers were able to maintain.
I would hate to think to where I would be without the care that I'm getting from Dr. Owens and her staff, and the palliative care team. I don't even want to think about it.
So he is now also waiting to get his complete clearance from his oncologist so that he can go forth and enjoy the things of life that he enjoys.
Well, I'm looking forward to, getting better and hopefully going back to work before too long, and just getting to feel better and, having a more active, full life.
So I'm glad you got a chance to just meet Steve briefly. Hi, my name is Maria, and our supportive and palliative team have had the honor of being just a small part of Mr. Nelson, which he likes us to refer to him as Steve's health journey. As many of us know, Austin is known as the live music capital of the world, and some of us at one time or another have had the opportunity to enjoy a concert or two. Prior to Steve's illness and diagnosis of cancer, he was living a normal life with his two best friends, which are his dogs, Happy, which is he's not very happy, he says, and his other dog, Gemma. Steve was working as a stage rigging technician and helped set up the large rafters and stage for large music events here in Austin, and he absolutely loved his job. Sadly, for the third time in his life, he was diagnosed with cancer and also was diagnosed with stage 4 kidney disease. Due to his illness, he was unable to continue working and found himself medically uninsured. However, thanks to Central Health and Matt, Steve was able to receive medical care and begin his healthcare journey here at Central Health. Steve first became part of the Central Health family and was cared by our amazing nephrologist, Dr. Lebetsky, and our GI team, Dr. Bashashadi and Rebecca. Our palliative team was the new kid on the block. However, Nami, who was Dr. Lebetsky's nurse, was very knowledgeable about palliative care services, and she knew that Mr. Nelson would need an extra layer of support and a team who could help manage his symptoms with his new diagnosis of cancer and his complex health conditions. In February of 2024, Mr. Nelson became our very first palliative patient. He holds a very special place in our hearts, just like all of our patients here at Central Health. As you can see in the video, he has a very warm smile, and that is what I remember most, in addition to his optimism when I first met him. But behind this smile, he was shouldering a lot. Not only was he concerned about his health, he also had other burdens. Due to not being able to work, he had many financial concerns and had many other barriers. He did not have a car, so he was very concerned about how he would get to his chemo appointments, and he also did not have very much family support. But most of all, he worried if he would lose his home and if he would become homeless. Our team worked closely with Steve, and he had the greatest wraparound care. From our disability coordinator, Becca, our transportation team, our dietitian, our PAP team who helped him get enteral formula feedings, other community partners along with his oncology team, we were all able to work together and ensure that his barriers were addressed and that he received the best health care. Our palliative providers did an amazing job managing his symptoms during his course of illness and have worked collaboratively with our other Central Health specialists and other community partners. I'm happy to say I just found out today that he is clear of his cancer, and now he can truly enjoy doing what he loves most, which he said is tubing. He wants to go out on the river and soak in a hot tub. So hopefully soon he will be able to be strong enough to go and work. The beauty of the story is that many people here at Central Health had a great part in making a difference in Steve's life. And I believe we are all making authentic, meaningful connection and making a true difference in our patients' and families' lives. I am proud to say that Mr. Nelson was able to qualify for disability benefits, and he has now transitioned over to a new insurance. However, he did share with me that he wishes he would not have signed up for a different insurance because, he said, I don't want to lose all the great care that I have received here at Central Health. Thank you all for allowing us to serve our patients here at Central Health and to be just a small portion and part of our patients' lives. This would not have been possible if it were not for each of you here, our Travis County constituents, our board members, and our partners. So thank you and for believing in our mission.
Thank you, and thank you so much for all that you do. Quickly.
Yeah, really quick. I'm just curious. Maybe you don't have to answer or something. I need to get answers. Why did he have to switch insurance coverage? So that's the question.
Whenever they meet us, you can answer that too, Dr. Lee, but primarily whenever you receive a certain income status, you reach a certain income status, it switches over to a different insurance. But he is with CHFA, which is now, he's still able to follow our doctors up until December.
Okay, thank you very much.
Thank you.
Thank you, Maria. Up next, we have Central Health Board Chair Ann Kitchen.
I'm just going to very quickly, I'm just on the agenda to let you know about something that we talked about earlier, so I'm just going to cut it short in the interest of time. But this is just to let everyone know that Central Health will have a groundbreaking event at Hancock Center Friday, November 8th, beginning at 9 a.m. So for the public, we wanted to make sure that we let them know that that was happening. And just as a reminder, we're converting the former Sears at Hancock Center at IH-35 at 41st Street into state-of-the-art clinical space and our new system headquarters. So please look for, I'm talking to the public now, please look for the announcement about this opening, and we hope that you all can join us. Okay, Yesenia, you want to go forward?
Yes. Up next, we have Central Health Board Member Cynthia Valadez.
Good evening.
Cynthia, if you want to go up here because you're part of public communications. Please, Dr. Lee did the, it's for the public.
Good evening, Central Health, and to the public. Today I received a communication from a group of doctors at CommunityCare who are outlining concerns of Central Health statements and communications, and I guess on the part of Dr. Lee as the CEO, and its impact on CUC's employees' morale, and also the perceptions that the CommunityCare patients may have after listening to these communications. The belief is that Central Health communications and actions appear to threaten the Central Health's substantial investment in community care reputations and standing in the community. The memo requests that Central Health cease regular communications to all community care employees that promote their view of conflicts between Central Health and CUC. Also that Central Health sees public communication that only presents their view of community care and Central Health conflicts as fact and maligns CUC. And finally, any communication to the public and community care workforce about the governance conflict and CUC's CEO administrative leave should be approved only by the CH and community care boards. The employment contract with Dr. Fournier is primarily with community care and contains provisions of his duties, termination reasons, compensation, etc. It is believed that if Central Health wishes to pursue a disciplinary action against Dr. Fournier, that Central Health should follow its own policy, HR 2-035P, and implement an independent investigation as has been discussed and is called for in the policy, and afford the entire Central Health Board pursuant to the policy where the Central Health Chair will schedule a meeting with the full board after an investigation is conducted where the board will be allowed to listen to the investigator, the complainant, and a representative of Central Health Management to present their respective positions. It is important to note that the Board of Managers drives any outcome to the governance issue through the investigation. Given that the Travis County Commissioners Court has directed Central Health and given us direction on keeping community care independent, it is incumbent upon this board to move deliberately and efficiently in handling the community care CEO matter. I formally request that Central Health staff cease to publicly continue to paint community care in a negative light, even though there may not be formal evidence on which to base any decisions on the CUC governance issue. That needs to occur. Any further communication to CUC should be channeled through the Board of Managers and the the Community Care and Central Health boards. And since we as a board have taken action to hire an investigator, we have not received any information as a result of that. I personally would like to make sure that that occurs as quickly as possible. We committed to the public and to the Commissioners Court and to ourselves that this would be taken care of in an expeditious manner. I ask that it do so. Thank you.
I'm going to say one or two things very quickly because, thank you, Cynthia, because of the statements that you just made publicly, which is your right. We have an agenda item that we will be actually taking up next in closed session. And that will address the timeline that you mentioned in terms of the investigation, and will provide this board an opportunity to have a conversation about that timeline. So, and if I heard you correctly, what I heard you saying to us is that you had received some communication from some employees at CUC, and so you wanted to, if I'm hearing you right, you chose this approach as a way to let us know that. Okay, thank you. All right, do we have any further?
Excuse me. And that was only because we have yet to have an opportunity as a board to
That's
discuss
okay,
this.
we'll
Thank
talk,
you.
we'll talk
Thank
about
you.
it. So, we'll talk.
Lastly,
Cindy,
yes,
is that all?
lastly, we have Central Health Board Manager, Amendment 20.
Okay.
Thank you, Chair, Vice Chair, and the entire board, of course. I'm speaking as not just a board member of the Central Health Enterprise, but also as a former MAP member and a former CommunityCare patient. And what I would like to share is really just a request, and it's that I implore all of us to consider that the charge that this board, or at least that I feel as a member of this board, is quite lofty, to ensure that we're doing our best to seek the truth, to ensure that Travis County taxpayer dollars are being provisioned and spent as intended. And in this process, I implore all of us to just dig as deeply as possible to keep our conversations as civil and friendly as possible. Thank you, Chair.
Okay, Yesenia, do we have any further public communication?
That concludes the public communication.
Okay, so we are now going to take a few minutes and proceed to the consent agenda, and then after that, we'll be going into closed session. So, do I have a motion to approve consent agenda items C1 and C2? Motion from Manager Valadez, second. Oh, I'm sorry. Second from Manager Musaitiv. All in favor?
Aye.
Okay. Okay, so we're now going to proceed to the regular agenda. And in order to manage our time, we're going to take our closed session items first. So we're going to move into closed session. So let me read the
Did you not want to
appropriate.
take the vote on the closed session item in case your quorum gets thin?
What did you say?
On the, on the LPPF item.
Oh,
item number
thank
one.
you.
That
As a
should be
reminder.
fairly
Yes,
quick.
we have to take the LPF item first, which is item number 1. Discuss and take appropriate action on the proposed mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2025 under the Local Healthcare Provider Participation Program in Travis County, and how the revenue derived from those payments is to be spent as required by Texas Health and Safety Code Section 298E.151. Let's see, do you have anything further, Katie? Okay.
Only available if questions.
Okay. All right, I'm ready to accept a motion on this item. Manager Valadez.
I move that the board approve the FY or fiscal year 25 LPPF mandatory payment rate at 6% of net patient revenue as recommended by staff. Thank you.
Have a second? Manager Musaitiv, all in favor?
Aye.
Aye. Okay. All right, so now I'm going to move us into closed session for items 3, 4, 5, and 6. I announced, let me read those first. Okay. Item number 3 is discuss and take appropriate action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. Item number 4 is discuss updates on matters related to a performance review by Mazars USA contracted by Travis County. Item number 5 is receive and discuss a briefing regarding the Birch et al. Lawsuit. And item number 6 is receive and discuss a briefing regarding the Travis County Healthcare District versus Ascension Health. I announce that the board is convening in closed session to discuss these items. Agenda item number 3, under Texas Government Code, Section 551.074, Personnel Matters, and Texas Government Code, Section 551.071, Consultation with Attorney. And agenda items 4, 5, and 6, under Texas Government Code, Section 551.071, Consultation with Attorney. So members, we're going to go into closed session now. Well, yeah. We're ready. Yeah, we're gonna. Okay, we're ready? All right, we're coming back into open session. It is October 23rd. The time is 9:03. We have one item left on the Board of Managers, and that's item number 2, which I think, given the time, that we'll need to postpone. And that's the update on the status of the Wins for Trust. Wins for Trust is a very important conversation for us to have, and it's not something for us to have at 9:03. So we're going to postpone that to the next board meeting. So the last item is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of, well, our next regular meeting is November 13th. We've talked about that we'll be setting a special call meeting, and we'll get the date for that. So I'm ready to accept a motion for adjournment of the Board of Managers meeting, then we'll come to executive meeting and just run through that in like 5 minutes. Is that okay? All right. A motion to adjourn the Board of Managers meeting by Dr. Brinson, second by Manager Motwani. All in favor?
Aye.
Okay. All right, y'all, we have the executive committee meeting, which we can do in like 2 minutes. So, today's October 23rd, and it is 9:04. The quorum of the committee is in attendance. I'd like to call to order the meeting of the Central Health Executive Committee. The first item is approval of the minutes. I have a motion from Dr. Musaidev, a second from Manager Motwani.
I'm not on the committee.
Oh, sorry.
I'm sorry.
Second from Dr. Brinson. All in favor? Aye. Okay, it passed. Packet, so we won't take a presentation at this time. If you have anything you want to add, I know that Manager May wanted to add something, and I think Manager Valadez did. So if you want to speak to that right now.
Thank you. I'm just going to make a request that next month. Thank you for getting that. Sorry. I'm making a request that next month we add an update on the reporting requirements for the hospitals regarding the immigration status. That's something that we had already heard some about last month or a couple of months ago prior to, but the November 1st deadline for the hospitals to start doing this requirement is coming up. So I just kind of want us to all hear what is happening with respect to that. Thank you.
Okay, thank you. Manager Valadez, did you want to add something?
Yes. Sims, which is
Okay.
Partner with Ham and doing the the CHAP extension for Sendero.
Yeah.
Had someone there, and I think it was their CEO or executive director, sent out a letter telling them that there were going to be services halted as of Friday.
Okay.
This past Friday.
Okay, so
and what I'd like to know is what the heck's going on with Sims.
Okay, so we'll add an agenda item with an update on Sims.
And how will that impact Sendero?
Yeah, and any impact on Sendero. Okay.
With respect to Manager May's item, and just let me know if you're not comfortable with this or if this is too specific. I spoke with David Chinkanchan at Workers Defense Project, and he is very, very closely involved, around that policy as well as around other states that have adopted it and best practices, and they're sort of planning for it. And if he may be able to be invited as a speaker, he's pretty really good at it. Thanks.
Thank you. That's helpful. That is very helpful. Thank you. Okay, so let's so that's item number 2. We're now going to move on to item number 3, which is confirm the next regular executive committee meeting date, time, and location. It's tentatively scheduled for Wednesday, November 13th. Okay, this time I'm ready to accept a motion for adjournment. The executive committee, Dr. Musaidev, motion. Dr. Brinson, second. All in favor? Okay. All right, we're adjourned. All right, thank you, everyone.